Welcome to the Case of the Month. In the last Case of the Month, I shared several examples of patients with carpal tunnel syndrome, highlighting how coexisting pathologies were identified using my dedicated carpal tunnel protocol. You can revisit this case in the Community Hub at ultimatemsk.com. In this current case, we explore a carpal tunnel look-alike. The patient was referred for a diagnostic ultrasound of the carpal tunnel and a consult for a carpal tunnel release, but was ultimately found to have an alternative diagnosis. This diagnosis explained the patient's symptoms, which closely mimic those of carpal tunnel syndrome. Let's get started. A 42-year-old avid mountain biker developed bilateral burning pain and numbness in the palmar aspect of the wrist and hand. At the start of the mountain biking season, he switched to flat handlebar grips, and his symptoms developed about 4 months later. During the winter, when he stopped biking, his symptoms improved but returned immediately in the spring upon resuming mountain biking. Over time, the symptoms began waking him up at night and did not respond to night splinting. He was subsequently diagnosed with carpal tunnel syndrome and referred for a diagnostic ultrasound and possible carpal tunnel release. On physical examination, the wrist and hand appeared normal with no thenar atrophy, and sensation in all fingertips was normal to 2-point discrimination. A Fehling's test was negative at 2 minutes, and a Tinel sign over the carpal tunnel reproduced the patient's symptoms. A diagnostic ultrasound was performed utilizing my carpal tunnel protocol. The protocol can be reviewed in the wrist module of ultimatemsk.com. Imaging the palmar cutaneous branch of the median nerve is part of my protocol. The palmar cutaneous branch is a pure sensory branch that arises from the median nerve in the forearm and typically runs adjacent to the radial side of the median nerve before terminating in the subcutaneous tissue, where it innervates the radial half of the skin of the palm. The short axis proximal to distal cineclip starts at the level of the pronator quadratus muscle. The median nerve is deep to the flexor carpi radialis tendon as labeled. Scanning distally towards the carpal tunnel, the palmar cutaneous branch is viewed as a hypoechoic small dot that is often best visualized between the flexor carpi radialis tendon and the median nerve. Its termination in the subcutaneous tissue confirms its identity as the palmar cutaneous branch. Variations in the palmar cutaneous branch are common and can include multiple branches, focal enlargements, and deviations in its course before terminating in the subcutaneous tissue. In this companion case, the individual was referred for a diagnostic ultrasound of the carpal tunnel, which revealed an anomalous palmar cutaneous branch of the median nerve, a completely asymptomatic finding. In the short axis proximal to distal cineclip, the palmar cutaneous branch bifurcates into an ulnar and radial bundle, both located in their expected position between the flexor carpi radialis tendon and median nerve. Note that the median nerve is bifid. The ulnar bundle follows a typical course towards the palmar subcutaneous tissue. In contrast, the radial bundle shows a marked enlargement coursing adjacent to the radial side of the median nerve before tapering back to its usual small hypoechoic appearance and continuing into the palmar subcutaneous tissue. In the case of the mountain biker, the palmar cutaneous branch is easily identified as a small hypoechoic dot in its typical position between the flexor carpi radialis tendon and median nerve. The median nerve appears normal in size and echotexture. Scanning distally towards the carpal tunnel, the palmar cutaneous branch moves towards the palmar subcutaneous tissue, where an irregularly shaped enlargement of the nerve becomes evident. Notably, the patient reported experiencing his presenting symptoms during sonopalpation of the abnormal segment of the palmar cutaneous branch. This abnormal segment is also visualized in the long axis transducer orientation. The ultrasound findings are consistent with a traumatic neuroma of the palmar cutaneous branch of the median nerve. The patient was advised to switch back to the round handlebar grips to minimize direct pressure on the palm, use well-padded cycling gloves, and adjust his hand positioning while writing. Within 4 months, his symptoms resolved. In this similar case, a patient presented with a palpable cyst in the palm of the wrist and reported paresthesias in the thenar region of the palm. He was diagnosed with carpal tunnel syndrome, likely caused by compression of the median nerve from the cyst, and referred for a diagnostic ultrasound. A short axis proximal to distal clip revealed the palmar-cutaneous branch of the median nerve as a hypoechoic dot in its expected position between the flexor carpi radialis tendon and median nerve. Scanning distally, the palmar-cutaneous branch was noted to slightly enlarge before becoming obscured by the ganglion cyst. Distal to the cyst, the palmar-cutaneous branch also appeared slightly enlarged with a hyperechoic rim consistent with perineural fibrosis refers to the thickening and scarring of the perineurium, or outer lining of the nerve, typically caused by trauma or chronic irritation. The patient subsequently underwent an ultrasound-guided cyst aspiration and fenestration of the cyst walls, along with a hydrodissection of the palmar-cutaneous branch to release adhesions with the ganglion cyst. Approximately 3 weeks later, his paresthesias had completely resolved and the symptoms have not returned several years post-procedure. These 2 cases highlight the advantages of using ultrasound in evaluating carpal tunnel syndrome symptoms. Ultrasound not only provides direct imaging of the median nerve to detect signs of compression, but also identifies secondary causes of carpal tunnel syndrome and can recognize carpal tunnel lookalikes as exemplified by these 2 cases. In summary, a structured carpal tunnel scanning protocol allows for a comprehensive evaluation of the carpal tunnel and surrounding structures. This thorough approach can uncover alternative diagnoses, ensuring accurate treatment strategies. I encourage you to share your thoughts or post interesting cases in the Community Hub at ultimatemsk.com.